So my question is that if an individual is having patent foramen ovale, if an individual, for example, is having ASD, so basically we are going to have two things associated with that: paradoxical emboli and cryptogenic stroke. Can anyone just explain both of them? What is cryptogenic stroke? What is paradoxical emboli?
So for paradoxical emboli, typically, when there's an embolus, it travels from the right atrium to right ventricle to the pulmonary to the lungs, right? And cause the
Yes.
lung pulmonary emboli. But in this case, if
Mhm.
there's a patent foramen ovale, it travels from the right atrium to the left atrium, going through the
Mhm.
left to the left ventricle, then through the aorta, it enters into the pulmonary and the circulation, systemic circulation, which can go and cause an emboli in the GI or
Mhm.
a brain a stroke or something. That's what we call the paradoxical emboli.
Perfect. And in this case, if we have stroke due to like paradoxical emboli, that's simply known as paradox, or that's simply known as cryptogenic stroke. Okay. Okay. Let me just ask you another question related to this. For example, if an individual is having atrial fibrillation, first of all, I want you guys to be telling me that there would be ectopic foci present where. Just tell me the specific location.
In the left
Left ventricle
atrial
appendage.
appendages.
In left atrial appendages, you are going to have clot formation. I am asking about the ectopic foci.
The atria.
Yeah, it is present in the left atrium, but I want you, yes, pulmonary veins, near the pulmonary veins. Just keep that in mind. So we are going to have like a procedure which is known as radio ablation. So for the radio ablation, we have to assess the left atrium through interventricular septum. We have to cut that. We have to reach the left atrium, and then we are going to radio ablate the ectopic foci, which are specifically present in close proximity or in periphery of pulmonary veins, which are draining blood into your left atrium. Is that clear? Hello?
Yes.
So
Yes.
here we have to go through this atrial septum. Just keep that in mind. If we want to radio ablate. So the next question is that in atrial fibrillation, you guys already know we are going to be having stasis. As a result of that stasis, what happens? Coagulation factors are going to come. They are going to form clot, specifically where left atrial appendages. Very high yield. Okay, is that clear? Hello.
Yes.
Okay, so these were the MCQs point which you guys must keep in mind. So let's discuss our next topic that is basically ventricular septum. Okay, so we know that there are two portions of ventricular septum. Can you guys just name them? Two parts.
Septum prim.
Mhm.
Oh, oh,
Membranous and
Me- Muscular.
okay, the muscular. Okay, perfect. Where do we commonly see ventricular septal defect in which, in the muscular portion or in the membranous portion?
Membranous portion.
Membranous portion. Perfect. Can you just tell me the heart sound associated with ventricular septal defect if an individual is having VSD?
Machine like.
Hollow
Machine like
systolic.
is for
that's
PDA.
PDA. It's
Hollow
a
systolic.
holosystolic. No, less than our border. Yes.
It's seen in the tricuspid area. VSD, hollow systolic murmur.
Could it be like left dorsal?
The right upper sternal border.
We can't hear you.
Hello, can you guys hear me now? Hello?
Yes.
Hello?
Yes.
Okay. So my question for you guys is that we have an individual, he is having VSD, right? Ventricular septal defect. I want you guys to tell me what would be the pressure changes in different chambers of heart. That is right ventricle, right atrium, left atrium, and left ventricle. What would be the pressure changes in terms of increased pressure or decreased pressure? What do you guys think? Just start from the right ventricle.
There'll be no changes with the right ventricles. Right
In the
atrium,
right,
sorry, right atrium.
okay, let's start with the right ventricle. What would happen to the pressure? Increase or decrease?
Increase.
Increased.
Increase. Perfect. What about your right atrium?
No change.
No
No
changes.
change.
Perfect. What about left atrium?
Increased.
Increase.
Increase.
Perfect. What about left ventricle?
Increase.
Increase.
Increase. Perfect. That's perfect. Okay.
Increased.
So these are some important points which you guys have to keep in mind. Okay. Another important point which you guys must know. For example, if the VSD is like small or if VSD is large, you have two conditions. In one individual, you have like small VSD. In other individual, you have large VSD. What do you think? What would happen to the intensity of murmur in small VSD and intensity of murmur in large VSD?
Small
It
will
will
be
be
increased.
decreased.
Be louder.
It will be decreased in large and it will be increased in small.
Perfect. So in the small defect, we are going to have like increased intensity. The reason is that the pressure difference would be more in that case. Okay. Hello.
Yes.
Okay. So I want you guys to answer me that what are endocardial cushion? They are derivative of which kind of cells?
Neural crystals.
Neural cells. Okay. So they also contribute in formation of both atrial septum and ventricular septum. Keep that in mind. Okay. Hello.
Yes.
Okay, perfect. So let's discuss some of of fetal circulation. Okay, okay. We have an individual. Let's suppose a baby, right? So in which portion of his let's suppose of his circulation in the fetal circulation we are going to have highest concentration of oxygen?
IBC.
Umbilical vein.
Umbilical vein.
In the vein.
Okay, umbilical vein. What else? In
IVC.
IVC as well. Okay, perfect. Okay.
Inferior vena.
Okay, perfect. So in the heart, I want you guys to tell me where do we have least concentration of oxygen? In
The coronary
Yeah,
sinus.
Coronary
actually.
sinus.
coronary sinus. And what's the reason?
Because
it
heart
carries all
is
the-
highly metabolically active, so it's
Mhm.
utilizes the maximum amount of oxygen from the coronary circulation.
and all of the
Okay.
deoxygenated blood drains there.
Okay. Okay, that's perfect. So heart normally is like metabolically active organ. So whatever is draining into your sinus, that is coronary sinus, would be having most deoxygenated blood. That's very important. Keep that in mind. Okay. So let's discuss something about ductus arteriosus. Which two factor helps in closure of ductus arteriosus? We have two important factors which help in closure of ductus arteriosus. Yes.
You can use NSAID, indomethacin, and oxygen.
Okay. Whenever the oxygen
We can't hear you, sir.
We can't hear you, Doc.
hello, can you guys hear me now?
Yes.
Okay.
Yes, we can.
Yes.
So
Mhm.
what's the other factor to close your ductus arteriosus? One is like increase oxygen.
Falling levels of
Falling
prostaglandins.
Perfect. Okay. Normally, if we have patent ductus arteriosus, normally how can I decrease the level of prostaglandins by administration of which drug?
NSAID.
NSAIDs.
Specifically, which NSAID?
Indomethacin.
Endomethacin. Perfect. That's really hard. You keep that in mind. Okay. Let's discuss some of cardiac anatomy. Okay. So there are different surfaces, borders of heart. I want you guys to be telling me that anterior surface of heart is formed by which?
Right
Which
ventricle.
ventricle.
right ventricle. Perfect. What about posterior?
Left
Left
atrium.
atrium.
Left atrium. Perfect. Okay, what about the inferior surface?
Both right, 2/3 of right ventricle and 1/3 of 2/3 of left ventricle and 1/3 of right ventricle.
Perfect. We have an individual. He's having he's having a stable injury between third and fourth intercostal, directed laterally. What do you think which structure is going to be damaged?
The lung.
The lungs. The
Okay,
left
if the
lung.
same injury is directed medially, what do you think which structure is going to be damaged?
The
Then
right
right
ventricle.
ventricle.
The right ventricle.
Right ventricle. Perfect. We have a stay wound injury at mid clavicular fifth intercostal space. Which structure is going to be injured?
Mm.
The apex, the inferior
Apex
The
of
inferior
the
first,
surface
heart.
of the
the
heart.
epic.
Left ventricle, right? That is apex
Yes.
of
Yes.
heart. Apex of
Mhm.
heart.
Apex.
Okay,
Yeah.
that's perfect. Okay, let me just ask you another question. We have an individual, he is having dysphagia due to atrial fibrillation. Can you guys just explain why?
Yes, left
Not
atria can be
nursing,
It's
not
having
enlarged.
a
syndrome due
stroke.
to left atrial enlargement.
Okay,
Enlargement.
left
Hypertrophy.
atrial enlargement. Perfect. If I want to take pictures of the posterior aspect of heart, I'm going to perform a procedure which is like transesophageal echocardiography, right? In which I'm going to insert a camera. I would just go to the mid esophagus. If I want to take the picture from the heart, what do you guys think? Which which part of the heart would be more like visible in that picture, for example?
The descending.
Left
The
atria.
left atrium.
Left
The
atrium.
Perfect. If
Oh,
now I
left.
just rotate it 180 degree and I want to see the posterior aspect, which structure
the
a picture
descending
am I going
aorta.
Descending
Descending
aorta.
And
aorta.
aorta.
Okay, that's perfect. Can you just tell me the what is Ortner syndrome, by the way?
It's
The
a
right
compression of the
ventricle is
vagus
in
nerve,
pieces.
compression of the vagus nerve and the esophagus as well as the left recurrent nerve because of the enlargement of the left atria.
Perfect. It's basically compression of your left recurrent laryngeal nerve, okay, due to enlargement of area. That's perfect. Okay, so let's discuss pericardium. What do you guys think? Can you just name the three layers of pericardium and its nervous supply?
Yeah, the fibrous
The parietal
pericardium, the
and the
parietal
medulla.
pericardium, and the epicardium.
Perfect. Can you just tell me which nerve just supply the pericardium?
Phrenic nerve.
Phrenic nerve.
Phrenic.
Perfect. Perfect. That's
The
perfect.
phrenic,
Let's
yeah.
discuss some of the blood supply, right? So we have right coronary artery, we have left coronary artery, right? So right, okay. SA node is supplied by which coronary artery, right or left?
Right.
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 AV node is supplied by
PDA, depending on the
PDA.
PDA.
dominance.
Right.
perfect. It depends upon the dominance, right? If
Hmm.
an individual is right dominant, because it's coming from PDA. If an individual is right dominant, it means PDA is going to arise from the right coronary artery. If he is left dominant, it means that it would be arising from the left coronary
Let's
artery.
circumference.
Yes, so AV node have its own artery, which is AV nodal artery, and it just arises from PDA. It means that AV node supply depends upon the dominance, right?
Yes.
Okay,
Mm.
that's perfect. So, can you guys just tell me different branches of left coronary artery?
The left anterior descending and the left
Mhm.
circumflex.
Okay, left circumflex. If an
Flex, yeah.
individual is left dominant, what do you guys think that PDA is going to arise from which of the following branch?
The left circumflex.
Left circumflex.
Left
Circumflex.
circumflex. Perfect. High. Okay, PDA is going to supply the inferior surface, right? We know that. Inferior surface of the heart,
PDA,
right?
the
Yes.
posterior. Okay.
Okay, perfect. It's going to supply the inferior surface. So we have right dominance, we have left dominance. We know that it's arising from left circumflex. That's very important point which you guys have to keep in mind. Let's discuss about papillary muscles. So LAD is going to supply which papillary muscle?
The posterior lateral.
LAD, anterior lateral.
Anterolateral.
The
Anterior
papillary
lateral.
muscle.
Sorry.
Anterolateral.
LAD.
Papillary
And
muscle.
AD anterolateral. Yeah.
Okay,
Yeah,
that's
flip
perfect.
the L and the A.
Anterior surface.
Yes, that's perfect. So let's discuss our physiology, right? That was all about anatomy and your embryology. So we'll be discussing some important points in physiology as well. The first one which we'll be discuss is stroke volume. What is stroke volume?
The total
Stroke volume.
amount of blood pumped out of the heart per minute.
In a single beat, right?
Yes, in a single
Yes.
beat.
Per minute or a single beat?
Single.
In a single
beat.
beat.
In a single beat. Perfect. Right? So there are certain variables on which your stroke volume depends. If the contractility increase, what happens to stroke volume? Yes.
Increase.
It
The volume will
increased.
increase.
Okay. If preload increase, what happens to stroke volume?
Increases.
Stroke
Okay.
volume
And
Increase.
increased.
yes,
Increase.
and this definition is basically satisfied by Frank-Starling mechanism, right?
Frank Starling.
What
Yes.
is
Yes.
Frank-Starling mechanism, and how do increased preload lead to increase, let's suppose, contractility or increase pumping power of your heart? Why?
Because the
Basically states that
stretch, yeah, the stretch of the muscle or something
Between
acting on my.
contractility and relaxation.
Okay. So as the preload increases, the stretch increases, which lead to increase or maximal overlap of actin and myosin filaments. And if we have maximum overlap of actin and myosin filament, it would lead to increase contractility, or the stroke volume is going to increase, right?
Yes.
Okay. What happens to stroke volume when the afterload increases?
It decreases
It decreases.
Perfect. How do we increase the afterload?
by
Increased pressure and
stooping,
valve
hand grip.
maneuvers.
Using peripheral resistance.
Okay, that
By
is
increasing
increase.
resistance.
The
Yes, by
vasoconstriction.
increasing resistance. How do we increase? If the arteriole constricts, right? Or like in
Mm-hmm.
chronic hypertension, both of these conditions, the afterload will increase. Okay.
Stenosis, yes.
Okay, perfect. So let's discuss our next. Okay, so for the stroke volume, can I just write down the stroke volume is equal to end diastolic volume minus end systolic volume?
Yes.
Okay, what
Yes.
is ejection fraction?
Screen is not
stroke
here.
volume.
What is the amount of
Stroke
blood?
volume by end diastolic volume.
Stroke volume.
Stroke
Stroke
volume divided
volume.
by okay, divided by end diastolic volume. That is like the fraction of blood which is like
Is
ejecting per total blood. So the total blood within the left ventricle would be end diastolic volume. Like in the end of diastole, the stroke volume is going to be leaving. So ejection fraction would be stroke volume divided by EDB, right? End diastolic volume. What is pulse pressure? Can you
stroke.
tell me?
Excuse me, sir.
Yes, please.
What did you say? You said I didn't understand what is stroke volume.
Okay, let me just.
You said stroke volume is end diastolic volume minus
Yes, like for
Ejection.
example, if
end
this is your
systolic
heart.
volume.
Yes, for example, if this is your heart, this is going to be your end diastolic volume, right?
Mm-hmm.
This is your aorta. Can you guys see my screen?
Yes,
Hello?
we
Yes.
can.
It's your end diastolic volume. Right after a single beat, stroke volume is going to exit into aorta, right? For example, this amount of blood is, like moved out, let's suppose, right? Now the amount of blood which is left is end systolic volume, right?
Yes. No. Yeah. I understand it, sir. Because I was just saying that it's minus because they say divided. So that's why I didn't understand.
The divided one is for ejection
Because
fraction.
it's end diastolic volume minus end
Yes.
systolic
So
volume. That's a
stroke
stroke
volume is
volume.
equal to end diastolic volume minus end
Minus.
systolic
Yes.
volume, right? I was just
Yes.
talking about ejection fraction. Ejection
Oh,
fraction
okay.
is stroke volume divided by end diastolic
End
volume,
diastolic volume. Yeah.
right? Okay.
Yes.
Let's discuss pulse pressure. What is pulse pressure?
Systolic minus
Pulse pressure
diastolic.
is systolic blood pressure
Minus diastolic
minus
blood.
diastolic
In
blood
certain
pressure.
conditions, the pulse pressure is going to be increased, right? For it, can you guys just name those conditions?
Hyperthyroidism and aortic regurgitation.
Hyperthyroidism and aortic regurgitation. Perfect. Okay.
Yes.
Let's discuss our next topic, that is going to be heart sounds, right? So we have S1, S2, S3, and S4. So I'll be asking you some questions. S1 heart sound. Okay, the heart sounds are basically, heard during closure of the valves or opening of the valves, first of all.
Closure.
Closure of the valve.
Closure. Perfect. S1 is due to closure of which valves? Just name them.
Mitral and tricuspid.
Mitral and tricuspid.
Mitral.
Perfect. Okay. S2.
Pulmonary and aortic.
Aortic.
Okay, it means that it have two components, right? What about
Yes.
S3?
In case of
S3
overload, volume overload or dilation.
overload.
Volume overload.
Perfect. Volume overload. So, can you guys just tell me that S3 would be heard in the early diastolic or in the late diastolic? Is it
Early
an
diastolic.
early diastolic? Perfect. So in volume overload, what happens? The chamber size increase. If the chamber size increase, so in the early diastole, which is basically a rapid filling, so the amount of blood is going to come, it's going to hit the surface of the blood, and we are going to hear S3 heart sound, right? So in which condition do we have volume overload? We guys know that in pregnancy, like we know that in the aortic regurgitation, we know
Blood
like in the heart
transfusion.
failure as well, right?
Yes.
Okay,
Yes.
what else?
Blood transfusions.
Blood transfusions, perfect. Okay, so let's discuss about S4 heart sound. So can you guys just tell me S4 heart sound is a late diastolic or it's an early diastolic sound? And when do we
Late
hear? Okay,
diastolic.
late.
Late.
Perfect.
Late
Okay,
diastolic.
what? Okay, so as we discussed that SC is basically, the amount of blood hitting the surface of the blood which is already present. So when do we hear S4 heart sound?
In
Forceful
case of
contraction of
stiffness,
the
there's like
hip
stenosis and he's forcing his way through the valve. Like
When
Okay,
blood enters
perfect.
the
Hypertrophy.
second.
Hypertrophy of
Mhm.
the heart.
Hypertrophy. So in the end, we are going to have like atrial kick. If we have a stiffened or hypertrophic wall, what happens? This atrial kick against the stiffened wall is going to give us S4 heart sound, right? Hello?
Yes.
Okay.
Yes.
If I want to hear these S3 or S4, I'll just hear it with the diaphragm on the stethoscope or with the bell of stethoscope.
bell.
the
Diaphragm.
this, the
Bell.
small parts, the
This,
bell.
The
small,
small,
the
the bell.
bell.
The
The bell.
small part is the bell, right? The diaphragm is
Yes,
the
the bell.
bigger part, okay?
The
Okay.
bell.
And in which state I'll be hearing that these sounds well? In the end expiration, in initial expiration state, or which state? Which state of your respiratory process or respiratory?
End expiration.
Why?
End expiration. Because the heart will
Closure.
be closer to the
Yeah.
precordium.
Okay, so the heart is going to be closer to your chest wall. So as a result of that, we can just hear these sounds quite well. Okay, so let's discuss S2 splitting. Can you just tell me what is physiological splitting of S2, the mechanism behind that, and things? Okay, let me just ask you a question. During inspiration, what happens to the right-sided preload and what happens to the left-sided preload, and why?
Right-sided preload increases.
Because of increased venous return to the heart.
Okay. Venous return increases during inspiration. Your right side is going to accept more amount of blood, so right-sided preload increases. While what happens to your left-sided preload?
Decreases.
Decrease.
Decreases.
Why? Because during inspiration, more of the blood is going to stay within the lungs, right? In order to get
Yes.
oxygen. Okay. So if the right-sided preload increases, so now it would just take more time for the pulmonic valve to close as the preload is increased. So as this increased amount of blood is passing through your pulmonary like valve or the right pulmonic valve, so it would take more time. It means that first of all, the aortic valve is going to close, and secondly, your pulmonary valve is going to be closed. So we are gonna
Sir,
see splitting, right? Yes.
can you explain why the left-sided preload decreases once? Thank you.
The left-sided preload. Okay. So what happens during inspiration as the thoracic cavity volume? What happens to the volume?
It increases.
Yes.
Increases.
Right. So for example, if this is your right side and this is your left side, right? So as the lungs are expanding, what happens? As the volume is increasing, the pressure is decreasing. So what happens? This decreased pressure on the right side is going to accept more blood, right? While your lungs are expanding, it means more blood is going to enter into the lungs in order to get oxygenated. So less blood is going to be drained into your left side, right?
Right. Thank you.
During inspiration. So left-sided preload is going to increase or decrease. Okay. So what happens? We are going to have here like splitting of S2. Okay. What about wide split? What is wide split? Yes.
When there's delayed right ventricle emptying.
Mhm.
It's an abnormal delay seen because of pulmonary stenosis or the right bundle branch block
Okay.
and delayed pulmonic valve closure.
Okay. So whenever we have like delayed right ventricular emptying or like pulmonic stenosis, right bundle branch block, again it would just take more time for the pulmonic wall to close. So we are going to hear like wide split, right? First of all, we are going to have closure of aortic, and it would take more time for the pulmonic valve to close. So that's why we're going to have like wide splitting. What about fixed slit? We discussed it's basically seen in ASD. And okay, what is paradoxical splitting? Yes.
Whenever aortic
Comes and
valve
goes.
closes
When the
When
later.
the
aortic
aortic valve.
valve is the one having delay in closure.
Okay, so first of all, we are going to hear P2 component and then A2 component, right? Which condition leads to paradoxical splitting?
Aortic stenosis?
Perfect. What about what else?
The left bundle
Oh,
branch block.
bundle branch block. Yeah.
Left bundle
Left on
branch.
the branch. Mhm.
Perfect. That's perfect. So, okay, so let's discuss about aortic stenosis, right? So you can you guys just tell me the murmur associated with aortic stenosis? Yes.
Crescendo, decrescendo.
Because
Perfect. It would radiate to which arteries, by the way?
The carotid.
Carotid. Perfect. Okay. So aortic stenosis. Can you just tell me some of the causes of aortic stenosis?
Potential
Most
angina,
common, most common cause of aortic
Age-related calcification.
calcification.
age-related
Calcification.
perfect. And this calcification, like for example, if you have an individual of 40 years of age, still he's having calcification. So, what do you think? What is the association with early onset calcification of aortic valve?
Bicuspid aortic valve.
Bicuspid aortic.
Bicuspid aortic valve. That's perfect. Okay. So, what there are going to be like some of the presenting features that is syncope, angina, and dyspnea as well, right? And the idea is really simple. Why we are going to have like syncope because we have stenosis. The blood cannot properly reach the brain, so it would just lead to syncope. What about angina? Because the afterload increases. If the afterload increases, heart is going to pump against increase afterload. It would increase the oxygen demand, and if we have demand and supply mismatch, this is going to lead to angina. What about why are we going to see dyspnea in this case? Because the blood is going to pull back within your lungs. You are going to have edema. As a result of that, we are going to experience dyspnea. Is that clear?
yes.
Okay. So mitral regurgitation. Mitral regurgitation. Can anyone just tell me the murmur associated with mitral regurgitation?
Holosystolic.
Holosystolic.
They
Holosystolic.
high pitched.
Okay, perfect. Would we be having S3 heart sound? What do you guys think?
Would we be having what?
Holo-
S3 heart sound in case of
Yes.
mitral
Mama,
regurgitation.
blowing mama.
Yes, because volume overload, backflow, because
Mama.
Yes, yes, like murmur, we are going to have like holosystolic murmur, but we can also have S3 heart sound because again, like the blood is going to be coming back in the it's a volume overload. So simple. What happens to afterload in case of mitral regurgitation? Afterload would increase or decrease.
Decrease.
Decreased.
Why?
Because of regurgitation, blood is going back.
And it's not moving forward.
So that's why afterload will be decreasing.
Perfect. We have like more places of the blood to go. Like it would just flow in the aorta as well as back within the metal wall. So we have two outflows now, right? So what happens to the afterload or the resistance? It will be okay. Oh, can anyone just tell me regarding rheumatic fever? Rheumatic fever. Early onset and let's suppose the late outcomes. In the early out, in early infections, an early rheumatic fever, would it lead to stenosis or would it lead to regurgitation? Can anyone just tell me something about that? In the
Early
acute stage.
cause
early onset will be
Regurgitation.
mitral regurg, right?
and the
Then
later
late
leads to
is
stenosis.
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 Perfect. The early would
Uh,
lead to regurgitation, the later would lead to stenosis.
Stenosis. Yeah.
Okay, perfect. Mitral valve prolapse. Can you anyone just tell me the murmur associated with mitral valve prolapse?
It's a mid systolic click. It's a
Chris,
click.
there's
Mid
crescendo mama
systolic.
also.
Okay, perfect. Crescendo murmur along with mid systolic click. Why do we hear that mid systolic click? It's a sudden tensing of your chorda tendon, right?
Opening.
Perfect. And like
Pushing.
Marfan syndrome can be one of the cause of mitral valve prolapse. Okay, so like infective endocarditis as well, rheumatic fever, and okay, ventricular septal defect. We already discussed that. Aortic regurgitation. Can anyone just tell me the murmur associated with aortic regurgitation?
Early Dasley. Early
High
Dasley.
It's
pitched
just
blowing.
a decrescendo. Yes.
Decrescendo.
Early
Early
Crescendo,
discharge.
diastolic
decrescendo.
Perfect.
Decrescendo.
It's a decrescendo murmur. Perfect. So, in case of what happens to pulse pressure in case of aortic regurgitation?
The
Why
patient will have
Increases.
headache.
increased?
They can have headache and then,
Pulse
Perfect.
pressure. It
Okay.
increases.
Hyperdynamic pulse, head bobbing, right? Pistol shot, if you guys remember in the femoral pulse,
Water
right?
hammer. Mhm.
Yes, water hammer, yes. Okay. Mitral stenosis. Mitral stenosis. What about the murmur associated with mitral stenosis?
Open snap.
Mid
Decreasing
diastolic
as
murmur.
MS.
It's a
Sorry.
diastolic with the opening snap.
Mid diastolic murmur.
diastolic
Yes,
murmur.
rumbling.
Okay, it
Rumbling.
would be a diastolic. That is
Endo-
delayed rupple, mid to late murmur. That is an opening snap as well, right? Opening snap, if you guys remember.
Yeah.
No? Okay, perfect. So, patent ductus arteriosus. What kind of murmur is associated with PDA?
Continuous machine like.
Machine
Machine
like,
type.
machine
Perfect.
like
Machine type.
murmur. Made a
Okay, that's
mistake there.
so let's discuss myocardial action potential, right? We have different phases of the action potential. Phase 0, phase 1, phase 2, phase 3, phase 4. So you guys are going to be telling me the ions flow associated with different phases of myocardial action potential. So for the phase 0, guess which ion is
Sodium.
responsible? Sodium.
Sodium.
Phase 1,
Potassium.
Sodium and potassium.
okay. What about phase 2?
Calcium
Calcium.
and potassium.
Potassium.
Perfect. What about
Because
phase
it's
3?
plateau. Potassium only.
Calcium.
Efflux.
Okay,
Efflux of
perfect.
potassium.
It's potassium, massive efflux of potassium. That is a repolarization, okay? And phase 4 is basically a resting phase,
The
okay?
phase 1 and phase 2 are absent in case of cardiac action potential.
Okay, so we are talking about the cells, right?
Okay. Okay.
For SA and
Okay.
AV node, there
Okay,
for
sir.
pacemaker potential, they aren't there, okay? We are talking about the myocardial cells, okay?
Myocardial.
So we have
Not
phase 0, phase 1, phase 2, phase 3. In the phase 0, basically, we're going to have like, influx of your sodium. In phase 1, it's initial repolarization, right? Phase 2 is plateau, right? Plateau, when do we see plateau? Whenever we have, calcium influx and potassium efflux, so we are going to have a plateau, right? And suddenly what would happen after that? The calcium influx would stop and potassium would just keep on going out of the cells, what would lead to repolarization, which is phase 3, okay? No?
yes.
Okay, so
Yes.
let's discuss about pacemaker action potential. Phase 0, phase 3, and phase 4. For the phase 0, which ions are basically responsible?
Calcium.
The calcium ion, the alkylated
Yeah.
calcium.
Calcium
Perfect.
ion.
L-type calcium.
Perfect. For phase 3,
Calcium,
The
potassium.
potassium.
Calcium, potassium.
That's
for the
potassium.
phase 4,
Phase 4
Phase
sodium
4
and
is sodium and potassium.
okay, that's
Mhm.
perfect. So let's discuss ECG a little bit, right? ECG, electrocardiogram. So basically, what is ECG?
Electrical charge of the heart.
Electrocardiogram.
Okay, so we have like different waves within the ECG. You guys are going to be telling me different waves, different segments, and what are the significance of them in case of your heart activity, right? So let's start with P wave.
Your atrial depolarization.
Atrial depolarization. Okay, in which
Yeah.
condition do we have absent P waves?
Blocks.
Block.
Atrioventricular blocks.
The heart
atrial
block.
fibrillation. AFib.
Okay.
Okay, atrial fibrillation. Okay, perfect. Okay, so what about QRS complex?
But wait, sorry, don't
Contraction
you
of
see
the
absent?
ventricle.
Don't you see absent P wave in like
Contraction.
third-degree blocks or something?
Okay, so basically in the blocks, we are going to have delay, PR interval, right? And the absence of P wave is basically seen in atrial fibrillation because the atria couldn't contract, right?
Okay.
Atria cannot get depolarized due to failure of contraction. So the P wave is going to be absent in atrial fibrillation. Okay.
Thank
So,
you.
okay. So, okay, what about QRS complex?
Ventricular depolarization.
Ventricular depolarization. Perfect. Okay, what about PR interval? What is PR interval?
Appear into
From when the atria start contracting to when the ventricles start contracting. So
So,
atria to
Can
ventricle.
I simply say that it would just signify the delay within the AV node?
Yes.
Sort
Okay.
of, yes. Mm-hmm.
If we have increased delay, or like if we have more delay of the impulses within the AV node, we know that impulses start coming from the SA node, it travels to the AV node in the bundle of His and then into your ventricles, right? So if we have more delay, what would happen to the PR interval? Increase or decrease?
Increased.
Increases.
increase.
Increases. Perfect. What is QT interval?
Your interval is between the ventricles. From the
Okay,
time that the
ventricular.
ventricles start depolarizing until it repolarize.
Okay, perfect. Okay. So, okay, we have, okay, like which anti-arrhythmic would just give us, okay, what is Torsades 3 points?
To start the
Prolongation of
If-
QT interval.
Yeah, prolongation of QT.
Prolongation of QT interval. And
Yes.
what things or what administration of which drugs would lead to this
Class
condition?
class 1 and class 3
Class
antiarrhythmics.
1 and class 3. Okay,
Antiarrhythmic.
anything which is like, affecting your repolarization, K plus, right? K plus channels, right?
Yes.
That's what. So we have atrial natriuretic peptides, right? What are ANP and what are BNP? What are their significance? ANP and BNP.
ANP released from the atrial when the atrial stretch is there, then it will be released, and BNP released from by the ventricular stretch.
Okay,
And
perfect.
they
Can I say
cause
that they are opposite to your RAS system?
yes,
Yes,
Yes.
because the
Okay,
merge.
what would it do to the level of Na sodium?
they cause the
They
They will
decrease.
reduce.
they cause the natriuresis and excrete
Reduce.
sodium more, so the sodium
Yes,
level
reduce.
low.
Okay, perfect. Sodium level are going to be reduced. Okay,
Reduce.
so we have an enzyme which basically degrades your ANP and BNP. Can you just name that enzyme?
Aldosterone.
Hello?
Aldosterone.
What did you ask,
We
Doc?
have
Aldosterone?
okay, we have, okay, that is neprilysin. Neprilysin. You guys know that it would
Ah,
degrade your ANP and BNP. And which drug do we give in order to degrade your neprilysin, or in order for the ANP or BNP to stay more in the blood and perform their activities? That is sacubitril, right? Perfect. That's perfect. So let's discuss about your receptors, right? So we have chemoreceptors, we have baroreceptors. Okay, so let me just ask you, give you a scenario. We have an individual, he's having a COPD, right? Hello?
Yes.
Very
yes, we
classic
can hear you.
MCQ, we discussed it a lot of time. We have an individual, he's having COPD. We won't give him 100% oxygen initially. Why?
Because
Because
the tissues are used to
Mhm.
reduce oxygen, perform.
Because
What
it
would
will
happen? Hypoventilation, hyperventilation. It's your task. You guys have to just tell me, okay?
Hyper,
They will lead to
there
hypoventilation.
will be hypoventilation.
Will decrease oxygen
raised
drive.
It would lead to
Respiratory drive.
hypoventilation. Why? Can anyone just explain me why?
Because
the
they depend
central
on the
chemoreceptor.
peripheral receptors for the drive of the respiration.
Mm-hmm.
Because
And
central chemoreceptors become less responsive to like
Responsive.
chronic
Mhm.
Okay.
oxygen, right?
In case of chronic hypoxia in COPD, what happens? Central chemoreceptor would just stop responding to your increased carbon dioxide, right? So what would happen if now only the peripheral receptors, which is basically responsive to less CO2, would be active, right? Hello.
Yes. Yes.
Then what happens if you are administering 100% of oxygen? What happens? It would lead to hypoventilation. We discuss everything in detail, right? Hello.
Yes.
Okay. Perfect.
We
So,
forgot.
okay. So the next topic, we are going to start pathology now, right? So let's discuss. Okay. So for example, if we have failure of neural crest cell to migrate into heart, it would lead to a condition. What's the name of that?
bronchoarteriosus, persistent bronchoarteriosis.
Persistent truncus arteriosus. Perfect. Okay, so what happens in persistent truncus arteriosus? We won't be having septum, right? Aorticopulmonary septum, right? So can I say that there would be a single vessel arising from both of your ventricles?
Yes.
Perfect.
Yes.
Now, if we have like the neural crest cells, if they migrate to the heart, but there is failure of spiraling of the septum, then we are going to end in a condition. What's the name of that?
Transposition of great
Transposition of great
vessels.
vessels.
TGA.
Perfect. Transposition of great vessels.
Great vessels.
Perfect. So we are going to have two circuits. Would oxygen administration improve the cyanosis in this individual? Yes
No.
or no?
No.
Perfect.
Well,
What would be the chest X-ray finding in case of transposition
Egg
of
on
the
a string.
Egg on string
egg on
appearance.
string appearance? Perfect.
Mhm.
What would be the initial management for this condition?
Keep the shunt
Keep
open.
the foramen open.
Perfect. Keep the shunt open. So we are going to have intermixing of blood, which is going to improve the cyanosis.
Dr. Ahmed,
Yes, please.
can you please make only one person respond because this is very confusing right now.
Okay, so please raise your hands before answering the question. Okay, let everyone participate. Okay, so I'll be just taking you guys name, and you are going to open your mic and then answer me. Okay, so the next condition which we are going to discuss is tetralogy of Fallot, right? So in tetralogy of Fallot, we are going to have four things within the heart, four problems, right? So Dr. Adonia is going to, okay, Dr. Abdul Rauf first. Dr. Abdul Rauf, can you just please turn on your mic? Okay.
Yes, sir.
In tetralogy of Fallot, we have four things, four problems within the heart. What are they?
So these are the pulmonary stenosis and right ventricular hypertrophy,
Okay,
overriding aorta, and ventricular septal defect.
ventricular septal defect. Perfect. So, for example, if you have a baby, he's having tetralogy of Fallot, the mother would, okay, if he's having, let's suppose, cyanotic spells, the mother is going to tell this baby to or this child to squat. How does squatting improve the cyanosis? Yes, Dr. Adonia. Adonia, can you just please turn on your mic?
So the squatting will cause decrease in the right to left shunt. So and it will improve the cyanosis.
Perfect. Perfect. Like what the squatting would do, it would increase the afterload. And as the afterload increases, now more blood is going to flow within your pulmonary system and is going to be oxygenated. Can anyone just tell me that would the ductus arteriosus, keeping open ductus arteriosus, help this condition or not? Yes or no?
Not really.
Yes, Daniela, what do you think?
Oh, sorry. I said not really.
It would help. It would help the condition. Okay. So,
yes.
like for
Why?
example,
Mhm.
like for example, if this is your heart, right? This is let's suppose your aorta and your pulmonary artery, okay, and this is your ductus arteriosus. So, if the shunt is open, the ductus arteriosus, so the left-sided pressure are more as compared to the right-sided pressure. It means that more blood is going to flow into the pulmonary artery, and
Yeah.
more blood is going to enter into your lungs, and it's going to be oxygenated more, returning into your left heart, which is going to help the cyanosis. Is that clear?
Thank you.
Okay. So yes, keeping open the ductus arteriosus would help this condition. Okay, it's basically related with DiGeorge syndrome. DiGeorge syndrome, right? Hello. What is
Yes.
DiGeorge syndrome? Yes, what is DiGeorge syndrome?
Can we answer?
Thymic
Failure.
hyperplasia
Okay.
Failure of the third and fourth
22 Q.
pharyngeal pouch.
associated
doctor.
with 22q11.
Okay, 22q11. We are going to have a lot of things, third and fourth pharyngeal pouch failure. That is thymic aplasia. We are going to have some facial problems. We are going to have like problems with great vessels of heart as well, which can lead to persistent truncus arteriosus along with tetralogy of Fallot, right?
Yes.
Okay, that's perfect. So ventricular septal defect, we discussed it. We discussed atrial septal defects. We discussed patent ductus arteriosus as well. Eisenmenger syndrome. What is Eisenmenger syndrome? Please.
When
Yes. Yes,
persistent
Danica.
Due to persistent VSD converting from left to right to left shunt.
Okay. So Eisenmenger is basically the whenever we have like left to right shunt for a chronic period of time, what would happen? It would lead to like a pulmonary arterial hypertension, which could lead to right ventricular hypertrophy, and the shunt would reverse, right?
Yes.
Okay. If the shunt reverses, that is, first of all, it was left to right. Now it would be right to left,
Right
right?
to left,
That's going
yes.
to lead to cyanosis. Perfect. Coarctation of aorta. So I want you guys to be telling me what is coarctation of aorta. Yes. Dr. Ramesh. Hello.
Yeah, so it's the constriction of the aorta.
Okay. Aortic narrowing. As a result of
Aortic
that, what would happen?
difference in the pulse pressure.
Okay. Difference in
In
the
both
pulse pressure. Mhm.
hmm,
Okay.
in
We're
the
going to
upper
have
and the
like
lower extremity.
collateral. We are having a collateral circulation, which would help shunt the blood into your descending aorta, by the way. Okay. So what would
Yes.
be the presenting feature of that if you have a lot of blood within the collateral circulation? So we are going to have some specific things related to that. What would be?
Rib notching on X-ray.
Rib notching. Perfect. Rib notching. What
Yeah.
else? We are going to have increased chances of berry aneurysm as well. Why?
Uh, due to persistent high pressure, systemic
Yes.
hypertension.
Yes, like if we have coarctation or narrowing of the aorta, so the proximal portion of aorta, which is basically supplying your upper extremity, is going to have a lot of pressure, right? Hypertension.
Mm.
And hypertension in that case is going to lead to berry aneurysm. Berry aneurysm is commonly seen where?
Cardiac
Um,
hemorrhage, increase.
anterior communicating artery.
Anterior communicating artery. Perfect. Okay. So the next topic which we are going to discuss is your hypertension. Can anyone just tell me what is hypertension by definition? What is hypertensive urgency? What is hypertensive emergency? Can anyone just tell me causes of hypertension?
Okay. Can I?
Yes, please.
Hypertension is basically like increased blood pressure and given by different values. If the blood pressure systolic is greater than 130 and the diastolic greater than 80, more or less.
Perfect.
Yes,
Okay.
and the urgency is severe when it's more than when the systolic is more than 180 and the diastolic is I think more than 120.
Yes. Okay. Do we have an organ damage in case of urgency?
No, we see that in
No.
emergency.
Emergency. Perfect. So
Yes.
chronic hypertension can lead to certain things like in the arteriole. Can you just tell me that?
Yes,
Which necrosis, by the
is it the fibro muscular dysplasia?
fibrinoid necrosis, right? Fibrinoid
Yes,
necrosis.
fibrinoid. Yes, the string of beads.
Okay, perfect. And we are also going to have like C arteriolosclerosis. Which type?
Hyaline.
Hyaline or hyperplasia? What do you guys think?
Hyperplastic.
Both.
Hyaline.
Both.
Hy-
Both
Hyaline.
hyaline and
Hyperplastic.
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 Hyperplastic. Okay. So that's all about. Okay, let's discuss atherosclerosis. Can anyone just tell me what is atherosclerosis? How do we get atherosclerosis from the really start? What are the fatty streaks and which factors would lead to proliferation? What are the form cells and everything? Because you guys have a lot of MCQs on atherosclerosis, so it's better to discuss entire atherosclerosis from start to end. Okay, so yes, Dr. Ramesh, can you just tell me? Okay, first of all, we are going to have like endothelial damage. Just after endothelial damage, what's going to happen? Yes, pathogenesis.
Can you repeat the what are you asking, doctor?
Okay, atherosclerosis. The first inciting event is going to be your inflammation, or that is endothelial damage, right?
Mhm.
After that, can you just tell me step by step mechanism what would happen next?
Okay, so there will be migration of the macrophage neutrophils or macrophages.
Macrophages, perfect. What would happen then?
Mm, then there will be accumulation of the lipids
LDL,
inside
right?
the yes
Mhm.
LDL inside the macrophages, giving rise to foaming
Foam cells
the foam cells. Yes.
or fatty streaks, perfect. What happens then?
Yes.
Smooth muscle cell migration as well, right? That is, you're going to
Yes.
have like, okay, which factors lead to smooth muscle cell migration? Name those factors, very high yield.
PDGF.
Okay, platelets derived growth factors and
If,
what else?
Fibroblast growth factor.
Fibroblast growth factor. Perfect.
yes. Yes.
Okay. Extracellular. Okay, then we are going to have like fibrous plaque and formation of atheroma. It can calcify with time, right?
Mm.
And it can lead to
Yes.
narrowing of the lumen, right? Which can lead to a lot of problems like angina as well. And we'll be discussing that. Okay. Cholesterol emboli, right? What are the characteristic feature of a cholesterol emboli? Very high yield. Very simple.
Cholesterol, emboli.
If we have an
Cause emboli.
embolus and it's like a, let's suppose a cholesterol embolus, the needle spaces, perfect. Keep that in mind. We're going to have needle spaces, right? That is like a hollow spaces, which basically, give us a clue that yes, there's a cholesterol emboli, right? Arteriolosclerosis. What is arteriolosclerosis? We have two types, hyaline and hyperplastic. Can anyone just tell me what is hyaline arteriolosclerosis, what is hyperplastic arteriolosclerosis, and how to differentiate them? Hello?
Hyaline is the thickening of the vessel walls, and
Okay.
the plasma protein leak into the endothelium
Okay.
in the
The hyaline.
hypertension, and hyperplastic is the onion skinning in severe hypertension with proliferation of the smooth muscle cells. Yeah.
Perfect. That's perfect. So let's discuss our next topic, that is aneurysm. Can you just guys tell me what is aneurysm and what is the most common cause of aneurysm? What is aneurysm?
Atherosclerosis?
No, and
No,
Aneurysm is
Thickening of wall.
inflammation.
is the
Inflammation of
dilatation
the
of the
cell
aorta,
wall.
pathologic dilatation of the
Pathological
aorta.
dilation
Yeah.
of the aorta.
Okay. Please, one by one. Okay. So it's basically an abnormal or pathological dilatation anywhere, right? It can be in your aorta. It can be like in your. Okay. So why do we get that pathological dilatation when we have weakening of the wall? And how do we get weakening whenever we have hypertension, right? The vasa vasorum would become thick. And if you guys remember the story, right? Hello?
Yes.
Yes.
So in case of aortic aneurysm, there are two types, thoracic aortic and abdominal aortic aneurysm. Thoracic aortic aneurysm, what's the cause for that? Hypertension, very high yield. Marfan syndrome as well, right? Tertiary syphilis, remember? And for the aortic abdominal aneurysm, what's the most common cause of that?
Atherosclerosis. Of smoking.
Smoking, very important, right?
Okay.
That's basically a transmural inflammation. That's basically a transmural inflammation which leads to abdominal aortic aneurysm. And what would be the presenting feature? We are going to have like a palpable pulsatile abdominal mass. Very important, right? And the rupture, if it's rupture, it can lead to hypotension and shock, right? Hello?
Yes.
Yes.
Okay. We have an individual, he's having a decelerating injury. Which part of the aorta is going to be prone to rupture?
Aortic isthmus. Aortic
Isthmus.
Aortic isthmus.
Yeah.
Perfect.
Mhm.
Aortic dissection. What is aortic dissection?
It is not here. Like, is it here?
Rupture. Rupture of the aorta.
Yeah.
It's just
intimal
a tear.
Rupture of the intima.
Formation. Okay, rupture of the intima, which is going to lead to a false lumen, blood present there, and problems, right? So that's basically aortic dissection. We have two types, type A and type B. Can anyone just tell me what is type A, what is type B? Stanford classification.
Type A is
Type A,
associated with the ascending aorta,
Okay.
and it extends to the aortic arch or the descending aorta.
If we have involvement of both ascending and descending aorta, would it be type A or type B?
Type A.
Type A. Whenever we have ascending aorta involvement, despite of descending aorta involvement, it would always be type A. So we have type A1 and type 2, right? The A is further divided into type 1 and type 2, right?
Yeah.
So So this was all. And what would be the treatment? Okay, it can also lead to cardiac tamponade. We guys know that whenever we have like proximal spread of that false lumen into the heart pericardium, it would lead to cardiac tamponade. And distally, it can also compromise upon the renal arteries. It can give us a lot of problems, right? Okay. So subclavian steal syndrome. Can anyone just tell me what is subclavian steal syndrome? We discussed it multiple of times. Yes. Here, okay, so in subclavian steal syndrome, we have stenosis of subclavian artery. Proximal to the vertebral artery or distal to the vertebral artery?
Proximal to it.
Proximal.
Proximal to the region
Yeah.
of vertebral artery.
Vertebra.
Perfect. If we have proximal stenosis, it would lead to what? Steal. What is steal? Backflow, right?
Mhm.
So my question for you guys is that how do the proximal stenosis leads to backflow of blood?
Decreased pressure on the distal lane, distal artery.
Mhm. Okay.
Reverse blood
Because
flow
of
in
reverse blood
in
flow.
ipsilateral
Because of the
vertebral
reverse
artery.
blood flow.
Okay, reverse blood flow. As distally the
Mm.
pressure is decreased, as the pressure is decreased, so the blood also always flow from high pressure to low pressure. So it will just keep on reversing, and as it keeps on reversing from the brain, right? So we are like vertebral artery supplies the brain. We know, right? Vertebral artery, basilar artery, pica, iliaca, posterior cerebral. We guys know that in detail, right? So if the blood is flowing back in the vertebral artery, what would happen as a result of that stealing? It would lead to vertebrobasilar insufficiency, ischemic pain of hand as well. Why?
Due to
Pressure.
decreased blood supply.
Pressure.
Yes, due to decreased blood supply, if you are just using the hand, as the blood supply to the hand is very less, so it could lead to ischemic pain, right?
Ischemic. Yes.
So let's discuss angina. So we have stable angina, unstable angina, vasospastic angina. So what is stable angina?
Pain
Yes.
on exertion.
Pain on exertion. If you are resting, the pain would get improved. That is the reason for that is atherosclerosis. If the atherosclerosis getting in 70% occlusion, it would lead to chest pain, right? And
Yes.
unstable angina, it's due to like thrombosis despite of rest. Like for example, it's the entire blockade of your let's suppose coronary artery, which is going to lead to ischemic pain, unstable angina, right? Hello.
Yes.
Yes.
Oh. So if we have stable, okay, if we have 80% occlusion, which layer of the heart is prone to ischemia? Like we have different layers of heart, right?
Subendothelial layer.
Subendocardial, right?
Endocardial, sorry, yes.
Alright.
Subendocardial.
In case of unstable angina, if we have entire blockade of your okay, so okay, on the ECG, what would subendocardial ischemia look like? Segment elevation or depression?
Elevation.
Depression.
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 ST depression.
ST depression. If we have, let's suppose thrombosis of entire coronary artery, right? It would lead to transmural myocardial infarction. So on the ECG, it would look like ST segment
Elevation.
Elevation.
Vasospastic angina. What is vasospastic or Prince metal angina? Yes,
And because of the coronary artery spasm.
spasm,
With
right?
the yeah.
Okay, so it's basically due to coronary artery spasm, and as a result of that, we're going to see like ST changes on ECG, right? So the trigger factors are going to be like cocaine, amphetamine use, alcohol, triptans, and the idea here is that basically we are going to have like problems with nitric oxide, and if you guys remember endothelin and nitric. Okay, endothelin is vasoconstrictor and nitric oxide is vasodilator. Normally, whenever we have acetylcholine release, nitric oxide is okay. Nitric oxide comes from which amino acid?
Arginine.
Arginine. Okay, perfect.
Arginine,
Right?
yes.
So
Arginine.
normally the parasympathetic stimulation is going to lead to release of nitric oxide, which is going to dilate your coronary artery. But in case of vasospastic angina, we are going to have like imbalance of both of these constrictors and dilators. Endothelins are constrictor. So as a result of in case of vasospastic, we are going to see more endothelin release. That is going to lead to constriction of your coronary artery, which is going to lead to vasospastic angina. Is that clear?
Yes.
Hello? Oh,
Yes.
so, okay. So let's discuss our next topic, which is, okay, just give me a second. Okay, so evolution of myocardial infarction, right? That is whenever an individual is having myocardial infarction. So as the time passes, there are going to have like a lot of gross changes within the heart, light microscopic changes, and some complication, right? So I'll be just telling you the time span. You guys are going to be telling me the gross changes, the light microscopy findings, and the complication, right? From 0 to 4 hours. What do you guys think? What would be the gross changes?
Regulating
The verified bus?
That is 0 to 24, not 4.
Nothing. Nothing. I don't know.
Minimal
Yes.
change.
Minimal change. In 0 to 4 hours, we are going to have, okay, what would be the gross appearance?
Oh, okay.
Yes.
To be normal, no change.
0 to
0
24
to
hours.
4. Yeah, 0 to 24.
And the light microscopy is going to like show you coagulative necrosis. Along with that, like we're going to have like wavy fibers. Okay, 0 to 4 hours, we are going to have like wavy fibers. Okay, and reperfusion injury. Along with that, as the calcium is like just flow like you know going back into that necrosed area. So we are going to have hypercontraction bands of myofibrils. Okay, 1 to 3 days. Which kind of cells are going to come?
1 to 3 days, you will have the inflammatory cells will be there, the
Okay, which
neutrophils,
Your
neutrophils?
neutrophils.
neutrophils.
Okay, perfect.
Macrophages.
What about 3 to 14 days?
Macrophages.
Macrophages. So
And granular
macrophages will just
cells.
come. It can lead to free wall rupture as well, tamponade as well, because the macrophages will be just eating all of the necrotic debris, which can lead to this problem. And 2 weeks to several months, it's going to lead to like a scar formation, right? Post myocardial injury syndrome as well. That is a scar formation, right?
Scar formation. Yes.
Diagnosis of myocardial infarction. So you guys are going to be telling me the significance of troponin I, the time, the time duration in which trop I increases, CKMB significance, what is CKMB and things. Yes, it would just give you an idea of reinfarctions and things. I want you guys to be telling me that.
First, the troponin I is the first to increase within the first 4 hours.
Okay, perfect. It
But
would
it's
remain elevated till how many days?
up to 10 days, 7
Yes,
Perfect.
7 to 10 days. Yeah.
to 10 days. Okay, thank
Okay,
you.
perfect.
7 to 10 days.
CKMB would increase in how many hours?
It's next. That's after 4 hours, 6 to 12 hours.
Perfect. And it would just remain at the peak for how much time?
That
16 to
phase,
24 hours.
yeah,
16
within
to
a day.
24. Perfect. So it's going to be like giving you an idea of reinfarction. Like for example, if an individual appear, he's having increased trop I. So as we know, trop I just stays increased for 10 till 10 days, right? So for example, if the CKMB would just raise like after 6 to 12 hours, it would just stay for until the peak for like 24 hours, then it would just come down. So right after 2 days, if still the CKMB is increased, we are going to assume that this individual is having a reinfarction, because after 24 hours, the CKMB should drop down, right? So the reinfarction, keep that in mind, very important, right? Hello?
Yes, sir.
Yeah.
Okay, perfect. So we have some topics remaining, so let's do it tomorrow, as we are going to do like like a little bit topics remaining, not much. Okay, so for today I think it was enough, and we are going to do like this revision session. As you know, cardiovascular is a little bit like a big system, so we are going to be doing it in 2 days. And did you guys like today's session of psychiatry with Dr. Moss?
Yes.
Yes.
Like you guys were just requesting again and again to have session with Moss, so that's why I just think of that it would be better. Okay, so a lot of students are concerned about the timings for the marathon, right? So as you guys know that we took a lot of break in between, like a break for Easter as well, for Eid vacations, and that's why the schedule is a little bit disturbed. But don't be worried, we are still here. We are going to finish off the entire things, okay? And one thing which I want to mention for the next Sunday, just get prepared for your NBME, all of you guys, right? Because the group we made for the accelerated period, there are very little students, like one or two students just participating in the NBME. Since your revision phase is also started, so each and everyone should participate in NBME, right? Online NBME, you guys have to purchase it from the official site, because like it's like of no significance that you guys aren't following, you guys are just only coming, taking classes, and you guys aren't following the other instructions, right? So it's for your betterment, and please just participate. And on the
I'm
Sunday we are
sorry.
gonna have.
Which one to purchase and be me?
Okay. So Dr. Hamza is going to be telling you which NBME are we going to do that. Okay. So just get ready for that. If you guys are doing some revision session, and on the you guys have forgot the Discord server. No one is there. That's of no use. What should you do now? You guys are already done with everything. It's your revision, guys. You guys should just give 1 or 2 weeks, since it's your end of preparation, and so just please follow the instructions. Just go to your Discord server, keep on discussing things with one another. Okay, so tomorrow we'll be continuing our session. Thank you so much, and I'll be sharing the schedule in a while. And have a nice day. Okay.
I
Thank
just
you
have
so
one
much.
question, Dr. Ahmad. So the next NBME will be the coming Sunday now?
Yes, for the coming Sunday, we are going to have NBME. Each and everyone should participate in that. Again, I don't want you guys to be, not participating in that. Those who aren't participating, just, you should just face the consequences then, okay? Because I'm just requesting you guys again and again to participate in the NBME, participate in NBME. I don't think so. Like, what's the problem? Since you guys are left with a very little things, right? Psychiatry would be completed in 1 or 2 days. Then you have your biostates, your biochemistry. If you guys aren't, interested, so please just tell us so that we also, stop this session and just focus on the other batch.
Dr. Ahmed, I think people feel a little bit less confident. That's why they are not
Don't be less
willing.
confident. I'm just telling you guys, you just follow the process, right? No, everyone just feel less confident. Even if it's your exam day, you would be never confident on your study, right? If you
Yes.
are here, it's not only about your preparation, just follow. If you are just telling you to give an NBME, after the NBME, we'll just decide whether you are prepared or not. Everyone feel that he is unprepared for his exam.
Okay.
Like that, you're going to, believe me, we did each and everything in a very big detail. Like, for the USMLE step 1, normally people just do 40 to 50% UWorld. They just give their exam, and that everyone just passed the exam. We did each and every MCQ of UWorld. We didn't miss a single thing. Be confident. Look, Dr. Judith just scored a lot of 85%, even doing 7 to 8 systems. We have
Yes,
Dr. Devya, she did 6 systems with us. She scored more than 60%. So if you guys aren't giving the NBME, the official NBME from the site, let me just tell you guys again, whoever is using copyrighted NBME, believe me, in the past, I have seen people, due to poor software, they were scoring 85% on that software, who are using copyrighted, and they failed their exam. Just go to the official site, the MCQ's distribution and the software there is exactly, not all of the MCQs carries same numbers or marks, right? There is a algorithm behind that. It isn't that one MCQ for single number. No, there is a proper algorithm of your official NBME. They are going to test you. Just don't rely on copyrighted NBME. That's a request, because I personally have seen. I'll just tell those students to share their experience. Okay, Dr. Hamza is going to tell you which NBME are we going to do. Okay, but just go to official site, just purchase the NBME, Doctor, and we are going to provide you the environment, real exam environment. Just go with that. Those who aren't confident, I believe that each and every student who just stay consistent till now are prepared for. I can just name them. They're entirely prepared for their exam. They can pass their exam, even if tomorrow they just sit in the exam. So don't be just, that I haven't completed this, I'm left with this, that. Just leave that. Go for an NBME. Okay?
Yes, doctor. Yes.
Okay. So I want you guys to be there. Okay, so Dr. Abdul Rauf, you should just give you an NBME, Devya, Daniela, Harshni, Ella, everyone should just give their NBME, right? And just be confident. If it's up to you, then you would never feel yourself confident for your exam. So that isn't the case. Just follow us if you are here in this platform with me, with your tutors, with Moaz, with Taha, with Mahin. So whatever we are just telling you, please follow that. Okay.
Yes, doctor.
Okay. Thank you so much.
That's
Thank you. See you tomorrow. Bye bye.
See you tomorrow, doc.
Bye.
Bye.